Hello, I'm Dr. James McKenzie. I am a chiropractor and I'm board certified in neurology. And today I'm going to talk about social anxiety disorder, aka social phobia. So what are we talking about? There's a fear of being embarrassed or being negatively judged in a social situation. Typical onset is age 13. It tends to be males more than females, but females can also have this issue. And frequently the onset of the first symptoms is preceded by an embarrassing moment. So usually something really embarrassing will happen, and from that point on, it triggers this disorder. So what we see here is marked anxiety about social situations in which the person will actually be or feel like they might be exposed. Social situations almost always provoke anxiety. The person avoids social situations and endures them with intense anxiety. So if they are able to even handle it, they're barely hanging on. They're just miserably stuck in a situation. Fear, anxiety, and avoidance that have lasted for 6+ months. So if it's less than 6 months, it doesn't qualify. Based on the diagnostic criteria. Symptoms cause significant distress or impairment in social situations, occupational situations, so obviously it can affect your ability to hold a job and the other impairment or important areas of function. It's not attributable to substances, medications, or a medical illness, and it's not better explained by any other mental disorder. The person has fears of being judged and as being anxious or unlikable or unattractive, etc. The fears that they will show their anxiety by shaking, sweating, etc. So, they might blush, they might tremble, things like this. It's just a constant fear of rejection or how they will be judged when they interact with people socially. There's an anticipatory anxiety that begins far in advance of the situation. So for example, if you know you're going to have to do something like, speak at somebody's funeral or something like that, you're going to feel obligated because it was somebody that, that you loved and cared about, but, just the fact that you're in front of all those people, you're going to start your hands might start sweating or something like that long before you even have the event. So oftentimes these patients avoid any kind of social situation, and commonly they self-medicate with alcohol, and they oftentimes drop out of school, and if they are at work and they're able to get to work consistently, oftentimes they're overlooked for promotions because they basically just avoid as much social interaction as possible. So there's some differential diagnosis considerations. Normal shyness is not the same thing. A panic disorder has its different criteria. Agoraphobia, again, these are just different things, but when as clinicians, we have to make sure that we can differentially diagnose so that we are providing the best possible treatment to specifically target this thing. So we have to look at the different options. Sometimes anxiety disorder looks the same or similar, major depression, and body dysmorphic disorder as well. So what's actually happening neurologically in the brain to basically have this diagnosis? We know that there's different circuits that are not working together very well. The cortical limbic circuitry, the corticostriatal circuitry. These are components of the temporal lobe, and basically we know these. So we know there's circuits that are not working together, and then we know that the amygdala itself doesn't work as well as it should. Prefrontal cortex, the hippocampus, and the striatum, which is deep inside of your brain, and it can even cause basically movement disorder kinds of things. These areas don't seem to fire appropriately together. they exhibit increased levels of glutamate content in the anterior cingulate region of the brain. Glutamate activity, we don't want it to be firing too high, because we see that with degeneration of the brain. Patients that have seizures have increased glutamate activity, and so this is something that we want to dampen and we want to calm it down. Foods like monosodium glutamate will increase this and make it worse. So diet is important. We also have aberrant striatal dopaminergic levels. In other words, the frontal lobe, which one of the things that it needs to fire appropriately is dopamine. And if it doesn't do that appropriately, then what we get is overfunction or escape of the basal ganglia, which is where the striatum is. So we want that whole circuitry to have the correct amounts of dopamine, and that helps the brain. And then what we also see with these patients is decreased serotonin levels. So if the patient doesn't have enough serotonin or doesn't have enough dopamine, there's actually special supplements that we can give them that will help their brain make it. So that helps a lot. What also increases the risk? First degree relatives. So if you have, a sibling or a parent or something like that, your chances go up by 10 times. That's significant. There is a genetic component here. If you look, there's an abnormal, so there's a gene that allows us to utilize serotonin. It doesn't work very well. Also, the ADRB1 gene and the RGSZ gene, these can be abnormal, and this is genetic. So, you can only do so much about your genetics, but the reality about genes is that usually they're expressed based on environmental stimuli. So we all carry good genes, we all carry bad genes. Some people have more good genes and some people have more bad genes. But how do we turn on a gene? It's usually things like diet and other things along those lines. So anything we can do to, to possibly turn off the gene, I'm not saying that it's possible, but I think it might be. Anything we can do to change, diet and decrease inflammation may actually help. Other things that we oftentimes see with this, these are what we call comorbidities. 20% self-medicate with alcohol. 20% also have depression and panic disorder, anxiety, mood disorder, avoidant personality disorder, or bipolar. So these are all things that we oftentimes see that accompany this particular thing. So we always have to look at what also might be connected. The standard of care right now is psychotherapy, which is good, and I always recommend to continue to use that. Relaxation techniques and the medications, there's different medications. All of them are trying to recycle what the patient doesn't have enough of. Or they're trying to stimulate certain receptors that are going to fire certain pathways of the brain that are going to make the brain work a little bit more efficiently. Unfortunately, all of them, except I don't think buspirone actually has side effects or adverse reactions, but the other ones for sure do. But these are things that we want to think about. So how can brain rehab help? So what I do with my patients is I try to maximize the function of their brain by doing brain rehab. And as I'm constantly modifying it and trying to improve it so that it's more and more effective. But what I would do for my patients, and this actually shouldn't say dysthymia, but anyway, what we try to do is we try to get labs so we can figure out what's not working right physiologically and biochemically, because the brain requires certain things to be just right, or it's not capable of being improved in its function. So we have to make sure that blood sugar is stable, we have to make sure there's no anemias, we have to make sure that there's no vitamin D deficiencies, we have to make sure that the brain is methylating appropriately, we have to make sure that there's no underlying infections or autoimmunities, things like that. These are very important. So we have to look at that. We also want to see if what areas of the brain are underactive or overactive, and we can figure that out with quantitative EEG. So we can look at brainwave activity, and it actually shows us what areas are working too well and which areas are not working well enough. And when an area is underworking or overworking, we know that it's degenerating. So what we want to do is we want to calm down the areas that are working too hard, and then we want to stimulate the areas that are not working hard enough. And we can do that utilizing neurofeedback. So we can actually change basically brainwave activity, and that can have very, very good outcomes for patients. Also, we would give you the appropriate supplements to nourish your brain and to try to help create the normal neurotransmitters that you're supposed to have, what everybody's supposed to have. And we also utilize interactive somatic exercises to retrain your brain. And we also give you special exercises to do at home that are going to balance out the two hemispheres of the brain. And then we also do things like pre and post testing to measure, to make sure that we're actually creating long-term change. Because ideally, if we can just get your brain to work as good as it possibly can, either your symptoms may go away completely, or at least they could be significantly lessened. So that would be the idea. So if we can work with your psychotherapist synergistically on your behalf, you know, we can do it in such a way that you know, you'll have the best outcome. So anyway, if you have any questions or you want to get a hold of us, this is the contact information. And we look forward to hearing from you and seeing if we can help you. Have a great day.